is a esteemed member of the Faculty of Health Department of the Pharmacy, University of Angers, France. And Dr. Flavien is a distinguished researcher with deep expertise in the neuropathic disorders and pharmacological innovation. His work focuses on developing novel therapeutic strategy for chemotherapy-induced peripheral neuropathy with the goal of reducing treatment-related suffering and improving the quality of the life, particularly in the cancer patients. He is actively engaged in mechanism-based drug discovery, collaborative research, and exploration of the new molecular pathway offering neuroprotective potentials. His impactful contribution to the global scientific community are reflected through his research publication and international engagements. His presentation today is entitled Development of the New Therapies for Management of Chemotherapy-Induced Peripheral Neuropathy. So I invite Dr. Flavien.
So the time for the talk is 15 minutes and the next 5 minutes for the questions round. Thank you.
So we will notify at 10 that 5 minutes left and then 1 minute before also. Yeah. So okay, that like it's okay, yeah.
So good afternoon, everyone. Thank you for this introduction. My name is Flavien Bessaguet. I'm an associate professor of physiology and pharmacology from the University of Angers in France. I would like to sincerely thank the organization to give me the opportunity to present my work today, and more precisely my previous work in my previous laboratory. And today I'm going to talk about the development of new therapies for the management of chemotherapy-induced peripheral neuropathy. So the chemotherapy-induced peripheral neuropathy is one of the major side effects of chemotherapy and is mainly observed with different chemotherapy like platinum salts, so for example oxaliplatin, the vinca alkaloids like vincristine, or taxanes like paclitaxel. And in patients, we can observe mainly sensory symptoms like paresthesia, but also hyperalgesia, so a high perception for a noxious stimulus, or allodynia, so a pain perception for a non-noxious stimulus. But there are also autonomic symptoms like blood pressure modification, digestive troubles, and more rarely, there are motor symptoms. So the mechanisms of chemotherapy-induced peripheral neuropathy is mainly depending on the molecules. To summarize, there are some chemotherapies that act on the axons, like taxanes or vinca alkaloids, that act on the depolymerization and polymerization of microtubules. And there are also cell platinums, for example, that act mainly on the cell body. So to summarize, they are neurons hyperexcitability with a high expression of different channels like sodium channels or calcium channels, but also there are metabolic disorders and oxidative stress that is associated with a neurodegeneration and mainly for the sensory neurons. But also the chemotherapy can act on the glial cells and for example the Schwann cells that is associated with a demyelination. And one other thing is that when the nerve is injured, the neurons can recruit different cells, and more precisely the immune cells. So there is generally an immune response in this peripheral neuropathy. Today, the current management of chemotherapy-induced peripheral neuropathy is based on two different approaches. So the first is non-pharmacological with mainly electrostimulation, like TENS. So it's the low intensity electrostimulation for stimulate the gate control and block the noxious stimulus. But there is also a pharmacological approach with topical therapy like capsaicin or lidocaine, and systemic therapy like different antidepressants, so duloxetine, venlafaxine, or tricyclic antidepressant like amitriptyline, imipramine, clomipramine, anticonvulsivant drugs like gabapentin or pregabalin, that is calcium channels blockers, and opioids. But all these different drugs are in fact often inefficient, but have large side effects. So there is a need to develop new therapies for manage these neuropathies. That's why we studied the renin-angiotensin system that is well known in blood pressure regulation. But there is also a RAS system in the central nervous system, and the activation of this system is associated with a neuroprotective effect in a large panel of different models, like a stroke, for example. And more recently, a RAS system has been identified in the peripheral nervous system and is also associated with a neuroprotective effect following a nerve lesion. As you can see here, the peripheral nervous system, and more precisely the neurons in the DRGs, so the sensory neurons, can express also angiotensin 2 and the receptors of angiotensin 2, like AT2 receptor. So briefly, the renin-angiotensin system is composed by angiotensin 1 that is cleaved by the angiotensin converting enzyme in angiotensin 2. And angiotensin 2 has two main receptors, so the AT1 receptor and AT2 receptors. For these studies, we used ramipril, that is an angiotensin converting enzyme inhibitor, the candesartan, that is an AT1 receptor antagonist, the PD 123-319, that is an AT2 receptor antagonist, and the C21, that is a direct AT2 receptor agonist that was supplied by a Swedish company, so the Vicore Pharma company. And the question was, do RAS modulators have effects on chemotherapy-induced peripheral neuropathy? So first, we developed a mouse model of vincristine-induced peripheral neuropathy because vincristine is a main chemotherapy extracted from Catharanthus roseus. You have a beautiful picture here. And is a treatment for mainly leukemia. But among all vinca alkaloids, vincristine is the most neurotoxic compound. And in patients, we observe mainly sensory symptoms like mechanical allodynia. So in mouse, to induce the peripheral neuropathy, we have administered vincristine daily during 1 week. And 1 day before the start of chemotherapy, we started the different treatments. So the candesartan with an AT2 receptor antagonist, the C21 with an AT2 receptor antagonist, and an AT2 receptor antagonist alone. Then we evaluated the functions of mice, so the motor coordination, the thermal nociception, the mechanical nociception, and the mechanical allodynia at day 1 and day 7. And at the end of the experiment, we quantified the intraepidermal nerve fibers in epidermis and the DRG neurons, and we evaluated the morphology of sciatic nerve. So first, we evaluated the mechanical threshold of mice with the von Frey filaments test. So you have the picture here. We used different filaments that representing different forces of pressure. And when the mice remove her paw, the force, the filament represents the mechanical threshold of the mice. And as you can see here, the vincristine induces a strong mechanical allodynia from day 1 to day 7. A treatment with candesartan was able to restore the tactile sensitivity at day 7, but interestingly, when we associated the candesartan with an AT2 receptor antagonist, we lost the beneficial effect of candesartan. That's suggesting that the beneficial effect of candesartan was depending on the AT2 receptor activation. And to confirm that, we tested the C21, that is a direct AT2 receptor agonist. And as you can see here, we observed exactly the same result for candesartan. And to confirm that, we demonstrated that the association with C21 and an AT2 receptor antagonist was associated with also a loss of the beneficial effect of C21. To go further, we quantified the intraepidermal nerve fibers in epidermis of the mice with a pan-neuronal marker, so the PGP 9.5. And we quantified also the DRG neurons with another pan-neuronal markers, so the beta-3 tubulin. And as you can see here, vincristine is able to induce strong decreases of intraepidermal nerve fibers density and DRG neurons. And candesartan and C21 treatment were able to counteract these diseases. Then we analyzed the morphology of sciatic nerve of mice, and vincristine induces the degeneration of large myelinated fibers in sciatic nerve, and vincristine induces also an arrangement of axon, because vincristine acts on the polymerization of the microtubules and modify modify the cytoskeleton of the neurons. And for these processes, only the C21 was able to prevent this process. Then we tested another pathway because we know that angiotensin II can be cleaved by angiotensin converting enzyme type 2 in another peptide, so the angiotensin 1,7, that is able to act and stimulate the AT2 receptor and another receptor that is the MAS receptor. And we tested here a specific and direct MAS receptor agonist, that is the Bio 101, that was supplied by another company, so the Biophytis. Because we knew previously that a MAS receptor activation was associated with an analgesia effect in a model of lesion of the sciatic nerve. So we administrated, as previously described, the vincristine daily during 1 week, and 1 day before the start of chemotherapy, we started the treatment with Bio 101. Then we evaluated the functions of mice, and more precisely the tactile sensitivity, and at the end of the experiment, we quantified the intraepidermal nerve fibers, the DRG neurons, and we evaluated the morphology of sciatic nerve. As you can see here, the Bio 101, so a MAS receptor agonist, is able to restore the normal mechanical sensitivity of mice from day 3 to day 7. And we confirm that the neuroprotective effect of Bio 101 was depending on the MAS receptor, because when we associated the MAS receptor agonist, so the Bio 101 with MAS receptor antagonist, so the A779, we lost the beneficial effect of Bio 101. To go further, we demonstrated that the Bio 101 prevents the intraepidermal nerve fibers and DRG neurons degeneration, and this beneficial effect was lost with a MAS receptor antagonist. Then in the sciatic nerve, we demonstrated that the Bio 101 prevents non-myelinated fibers degeneration. In parallel, we developed another mouse model of chemotherapy-induced peripheral neuropathy and a model of paclitaxel-induced peripheral neuropathy. Paclitaxel is a chemotherapy synthesized by several species of yew tree, like Taxus baccata, and is mainly a treatment for solid cancers, like drug cancer or breast cancer. But among all chemotherapy, the taxanes, and more precisely paclitaxel, are the most neurotoxic compounds. In patients, we can observe paresthesia and mechanical allodynia. To induce the peripheral neuropathy with paclitaxel, we administrated 4 times each 2 days the chemotherapy. And 1 day before the start of chemotherapy, we tested, we started the treatment with ramipril and an AT2 receptor antagonist. And then we evaluated the functions of mice, and we quantified intraepidermal nerve fibers in epidermis, the DRG neurons, and we evaluated the morphology of synaptic nerve. So as you can see here, the paclitaxel induces tactile allodynia from day 7 to day 13, which is reversible by day 20. So in the figure, it's the curve in red. Then we demonstrated that the ramipril was able to prevent the development of this neuropathy. So it's the curve in green. But interestingly, the association with ramipril and an AT2 receptor antagonist was associated with a loss of beneficial effect of ramipril, that suggesting that the neuroprotective effect of ramipril was depending also of the AT2 receptor activation. So to confirm this hypothesis, we tested the paclitaxel and the ramipril on a genetic model of mice. So the knockout mouse for the AT2 receptor. And as you can see here, paclitaxel induced tactile allodynia from day 7 to day 13 in this genetic model of mice. But interestingly, in this mice, the beneficial effect of ramipril was lost. So we had the confirmation that the beneficial effect of ramipril was depending on the AT2 receptor activation. Then we quantified the intraepidermal nerve fibers in epidermis and in the DRG neurons, and the paclitaxel induces a decrease of intraepidermal nerve fibers and the DRG neurons. And the ramipril was able to prevent this degeneration. In the synaptic nerve, we observed that the paclitaxel induces a decrease of myelinated and unmyelinated fibers density, and ramipril prevented only the degeneration of myelinated fibers. But now the question is, what is the specific mechanisms of ramipril? One possible neuroprotective effect of ramipril is when the ramipril blocks the angiotensin converting enzyme, it stimulates another pathway where the angiotensin 1 is cleaved by the angiotensin converting enzyme type 2 in another peptide, so the angiotensin 1,9, and this peptide is able to stimulate directly the AT2 receptor. But now the question is, what about patients? And we asked ourselves, do patients treated with RAS inhibitors develop fewer sensory symptoms following chemotherapy? So we conduct a clinical trial, so the name was Oncotox etc. So we enrolled 120 patients, and we divided these patients in 2 groups. One group with a previous treatment with RAS inhibitors, and one group with no treatment with RAS inhibitors. And we followed the induction of peripheral neuropathy following chemotherapy. So with questionnaires, we evaluated the severity of the sensory neuropathy, the neuropathic pain, the daily activities of patients, the quality of life of patients. We've treated with platinum salts and taxanes, and we also evaluated the pseudomotor functions with the pseudoscan, as you can see here, in hands and in feet. The only thing that we demonstrated is that the patient previously treated with RAS inhibitors develop fewer sensory symptoms when they had treated with a platinum-based chemotherapy. Before I finish, I would like to talk about the human immunoglobulins. So human immunoglobulins are a blood-derived medication from a pool of healthy donors. This is composed by IgG, IgA, and IgM. And these immunoglobulins are the treatment of autoimmune diseases or immune deficiencies. And the main mechanism of actions of human immunoglobulins is based on the reduction of the recruitment of inflammatory cells, the reduction of release of pro-inflammatory cytokines and chemokines, because, as I said in introduction, when the neurons are injured, they can recruit different immune cells. So for this study, the question was, do immunoglobulins treatments have a neuroprotective effect on chemotherapy-induced peripheral neuropathy prevention? And these immunoglobulins were supplied by another company, so the CSL Behring. Then we tested the human immunoglobulins on two different models of chemotherapy-induced peripheral neuropathy. So the vincristine-induced peripheral neuropathy and another model based on the oxaliplatin. And to induce the peripheral neuropathy with oxaliplatin, we administered 3 times each 3 days the chemotherapy, and we started the human immunoglobulin treatment 1 day before the start of chemotherapy. Then we analyzed the function of mice, and we analyzed the tissue of mice. So we first demonstrated that the human immunoglobulins prevent the tactile allodynia induced by the vincristine, so it's the B in the panel. And human immunoglobulins were able to prevent the neurodegeneration, so the decrease of intraepidermal nerve fibers density, the decrease of neurons in the DRG, and the decrease of myelinated fibers density. In oxaliplatin-induced peripheral neuropathy, we observed 2 different things. The first is oxaliplatin-induced cold hyperalgesia. That is a typical thing of this chemotherapy. And we also observed mechanical allodynia. And human immunoglobulins prevented cold hyperalgesia and tactile allodynia. And finally, human immunoglobulins can prevent the intraepidermal nerve fibers degeneration, because as you can see here, in this model, oxaliplatin does not induce degeneration of DRG neurons or in myelinated fibers in the sciatic nerve. So to conclude, we showed and we demonstrated that when we block the AT1 receptor with candesartan, we promote the activation of AT2 receptor with angiotensin II that is associated with neuroprotective effect, but a direct activation of AT2 receptor with C21 was also associated with a neuroprotective effect. Then we demonstrated that a blockage of angiotensin converting enzyme by ramipril is associated with another pathway, so with the formation of another peptide, so the angiotensin 1,9, that could be associated with direct activation of AT2 receptor and a neuroprotective effect. Then we demonstrated that the Bio-101 has also a neuroprotective effect with a specific activation of mast receptor. But finally, in patients, the question was is also open, because this clinical trial was led on a few patients and in a monocentric study. So we have to contend that with more patients and with a pluricentric cohort, pluricentric study. Then we demonstrated also that human immunoglobulins were able to have a neuroprotective effect in our different mice model. Before I finish, I would like to thank all people that has contributed to this work. So the Hospital University of Limoges and the research team, so and more precisely the Dr. Claire Demiot, the different companies that were supplied the different compounds, so the Biophytis, CSL Behring, and Vicore Pharma. And I would like to thank again the organization of the meeting for the invitation and for kindness. Thank you for your attention, and if you have any question, don't hesitate. Thank you very much.
Thank you, sir. Very informative presentation. So I want to know, only ramipril is very important for prevention the neuropathy. Other groups drugs like the uh, candesartan, losartan, what are the other things?
Sorry, can you repeat the questions slowly?
You said that ramipril is preventing the chemotherapy-induced peripheral neuropathy. What's about the other molecules?
Other molecules? Sorry, I didn't
Other
question.
drugs, other drugs.
Sorry?
She was asking about other drugs of the same class. Is it only specific to ramipril or
Other drugs.
That's
Lisinopril
yeah,
or
that's a good question. In fact,
yeah.
there are also different studies about RAS inhibitors in general. So it's well a class effect. So an angiotensin converting enzyme inhibitor has a neuroprotective effect. It is demonstrated in a large panel of different models of peripheral neuropathy, like diabetic neuropathy. And that's the same for AT1 receptor antagonists, so candesartan, etc. Yeah,
Okay, thank
it's
you.
already demonstrated.
Okay, thank you.
Yeah.
Thank you for the wonderful talk. I enjoyed it. My question, I have a number of questions, but the first one is your paradigm was prophylactic treatment. So you were giving it
Yeah.
Have you tried when the neuropathy has developed to see if drugs work after the neuropathy has developed?
To have a curative treatment, in fact, that's the question.
So, like, if you give paclitaxel for the drug afterwards.
Yeah, that's a big question, but for us, we started the different treatment before the chemotherapy, because in the medicine, we know that a patient is able for a chemotherapy. So we would like to have a preventive approach to limit the development of the neuropathy. But we didn't know that it's possible to have a curative effect with our drugs. Yeah.
Okay.
Yeah.
Thank you.
We didn't try.
Okay, thank you. The second question is a technical. How did you
How did you, sorry? How we evaluated this possibility? There is different tests for this cold hyperalgesia. The first is injection of acetone on the paw, because acetone, when is on the skin, it stimulates the channels of the perception of cold, like TRPM8, for example. And for this test, we quantified the time during the mice leaking or had a freezing of the paws. For here, we tested with a jump test. So there is a range of temperature that decrease each minute, and we quantified the jump of the mice.
Thank you.
Very nice presentation, Monsieur. So, ACE inhibitors, as ramipril, they are one of the side effects of it is dry cough, as we go through, right?
Yeah.
So that is because of increase in kinins, as they say. So did you look into kinins or any other related things in your studies, or are you planning to?
Any others?
So ACE inhibitors not only inhibit angiotensin converting enzyme, but they also inhibit the metabolism of kinins. That is why one of the side effect of it is called dry cough. That's what we study in this thing. So did you look into any metabolism of kinins, or did you look into kinins as markers?
Not really. We didn't evaluate this part. We concentrated only on the sensory symptoms and motor symptoms of the mice, and we analyzed the tissue of the mice. This part we didn't evaluate it. It's a big question. Yeah. Thank you very much.
Hello, sir. Nice presentation. I have one question doubt that renin inhibitors have a side effect which increases the potassium level in the blood.
What is the mechanism of the neuroprotection?
Renin inhibitors cause a side effect which shows that high level of potassium,
Yeah.
which causes the disruption in the neurons formation.
Sorry, I didn't catch the question.
Renin inhibitors increases potassium
Yeah.
as in side effects. Due to
Yeah.
high potassium, it causes a disruption in the neurons. Have you seen in this perspective? Or?
No, we didn't evaluate this part, but it's really interesting, in fact. But we didn't try and we didn't evaluate this thing. Yeah.
Okay, sir. Thank you.
Thank you. A pleasure.